My name is Jose Zuniga. I'm Life AIDS Care, and I am thrilled to chair this last session, which I hope will be provocative and allow us to have follow-on discussions, perhaps about issues that have been raised throughout the summit, maybe some issues that have been missed, some questions that we may have of you directly as we talk about how we navigate the intersection of the HIV care and prevention continuum. I'm grateful that I'm joined up here. We need one more person. Thank you. By the co-chairs of the summit, Dr. Kenneth Mayer and Dr. Julio Montaner, who will open this session with a few remarks and insights into what they've heard at the summit. And we'll follow on with discussants, Jane Anderson, Patrick Oyaro, Jorge Sanchez, and Kenley Sequese, all of whom you have been introduced to in prior panels.
Okay, we're going to do it from here. We'll be nice and informal. So first of all, I just want to congratulate all of you who are here, still at the end, the bitter end, but it's been an incredible couple of days. Just the stimulating conversation is unparalleled, and for that I think we owe a round of applause to the IAPAC and particularly to Dr. Zuniga for putting together such a wonderful conference. One of the interesting concepts that we focused on over the last couple of days, which I think has a lot of traction, and leaving here I think we're all going to be thinking more intently, is the whole idea of microepidemics. Many people have talked about it in the past, but I think this very focused initiative on IAPAC's part, I think, is to be commended. I come from Boston, and one of our famous politicians, Tip O'Neill, said all politics are local, and I think we also see all epidemics are local. But there are some themes that I think emerged here. Certainly, if we're talking about how to control the epidemic, one of the key issues that we have to think about is the pot is not necessarily going to get hugely larger overnight, and that means that to treat more people and to provide more kinds of prevention, we have to think about how we can be more efficient and more effective. So some of the things we're all going to have to think about over the next few years are we monitoring people in the most appropriate ways that need to be done? People talk about CD4 diagnostics. The question is really, what is the role of CD4 in an era where the ultimate measure is virologic suppression? There's no quick and easy answer, and certainly I think in future meetings, thinking along with some of the diagnostics manufacturers is going to be an important part of the conversation. Scaling up testing. Some very interesting conversations about the role of self-testing. On one hand, our mantra is the more often people test, the more they are aware of their serostatus, the more likely they may be to engage in care, but lots of concerns raised about people testing and not having an easy way into the public health system. We're talking about the whole issue of the cascade, and some of the other models that we need to think about and maybe spend more time actually talking about operationally are the use of peers, the use of health system navigators to help in some of these ways, so that when people initially test, there are people to help them get into the system, to navigate the system, to retain them in the system. Another area that was mentioned but may deserve more focus is the whole use of e-technologies, m-technologies, given the prevalence of cell phones in places that are heavily impacted by the epidemic. So I look forward to future conversations about that. But clearly, this whole issue, again, of focusing on serostatus awareness, focusing on key populations, the flip side, as many people in the room have mentioned over the last 2 days, the concerns about unintended consequences of increasing stigma. And we have to be attentive to that and attentive to really working in all different areas of civil society to ensure that as we ramp up testing, serostatus awareness, create demand generation for getting on treatment, staying in the system, that we're not also leading to further stigmatization and polarization. Last set of issues. I was very gratified at this meeting compared to 2 years ago and last year that there was more constructive dialogue about the different kinds of prevention, about primary prevention, secondary prevention, and that we see this less as an either-or. We know that there are finite health care dollars and resources, but we don't want to say people who are at risk for HIV shouldn't have access to pre-exposure prophylaxis because we don't have everybody treated. We obviously have urgent needs that have to be addressed in both quarters. The last thing that we touched on, and I think is a real challenge for Ambassador Birx, and who's really wonderful to be able to be here throughout the whole conference and to be so present and so attentive, is the opportunity and the challenge to see the increasing access of people to care for the HIV infection to enhance health care for other coexisting conditions. So obviously, if we're talking about women, we have to think about reproductive health, maternal child health issues that get built in above and beyond the provision of antiretrovirals. We have to think about sexual health for people at high risk for HIV, which includes access to diagnostics and treatment for other STIs, and certainly as much as we think that treating more people in places that have high TB burdens will attenuate the TB epidemic, it won't do it overnight. And so thinking about how we can leverage these programs focused on HIV to also enhance TB care as well as viral hepatitis care, I think is increasingly important. So I don't think we've come up with all the answers, but I think that it's been a very stimulating, thought-provoking meeting, and I'm certainly leaving here with a lot of new ideas.
Thank you, Ken. And again, I want to echo your opening remarks and thank IAPAC and Jose in particular for all the support, the enthusiasm, and the conviction that he has brought to the table to try to support the continued fight for a better placement of antiretroviral therapy as a key component of a combination prevention strategy. This has been a very good meeting for me in particular, not just because I got my award, which I thank you for as well, but because I come to the realization that if we were able to turn Alan Whiteside on our side, we can turn anybody. If you only knew how difficult that was. So on a more serious note, it's been a long struggle, campaign, battle, but what it was a crazy idea a decade ago, it has become a reality. And the 90-90-90 target that Michelle presented earlier this week, which will be formally presented at ANGAS next week, represents really the culmination of a very concerted work by a number of people, many of them represented here, that really, I believe, has the potential of being transformational in the way that we control the HIV/AIDS epidemic. When Michelle put the 90-90-90 trial balloon, so to speak, at Melbourne, and received an immediate endorsement by David Birx, we felt we knew we were on the right track. That was extremely gratifying. I'll share with you the secret that my friends at UNH were quite nervous going into that meeting, and your support was critical to consolidate the enthusiasm behind the strategy. I think that Debbie also has to be given the credit for highlighting for us the fact that it's not just having the targets, but how we're going to get there. And I really like her right thing, right place, right time sort of slogan because it helps us to focus our attention. How are we going to get this done? And while we have spent a lot of time having this discussion as to whether this was the right approach or not, now that that discussion is behind us, I think that focusing on what is the right thing to do, and what is the right place to do it, and what is the right time to do it, how are we going to get there is very important. On that note, I was having a conversation with Meg. I'm not sure if she's still, she won't let me close to a microphone with her. Anyways, I require close supervision. I was having a conversation with Meg about the fact that, sometimes people misinterpret some of the presentations, some of the speaking, some of the language, as if the targets and the guidelines somehow were in conflict. And nothing could be farther from the truth. I want to go on record, and I said it before, I'll say again, the 2013 guidelines was the most progressive set of guidelines that we ever saw in the field of HIV. They were right. They were excellent, and they really made it possible for us to start talking about very ambitious targets. The target necessarily is not tied to a guideline because guidelines will continue to evolve, and they are evolving in front of our eyes. The 2013 guideline today, as it was argued by Ben earlier today, there is new evidence that needs to be accommodated, and the process is underway, and we are delighted that that is the case. But again, feeding on Debbie's theme, we are going to need the normative guidelines to be more than just about the when to start, and they are, of course, but the focus should just not be about the when to start, but rather how do we incorporate all of these multiple opportunities that we have to get the best combination prevention package in front of our implementers, and so that they can do the right thing. And as I've been arguing for some time, we need to start opening these discussions to the people that are actually implementing out there. We have been talking to each other for too long. We need to get out of the small circles in which we travel most often, and bring these discussions and interact closely with the people that are implementing in the field, so that we can benefit from better understanding where their challenges are and how can we help them to overcome them. In the context of doing the right thing at the right place and the right time, the issue of hotspotting comes to mind, and the city's initiative builds on that theme, of course. I'm extremely supportive of that approach. I think it's we have to go where the money is, no doubt about it, but we have to be careful that we don't carry it away and we start excluding people all over again. Because if 55% of the epidemics in the cities, where 45% is elsewhere, and so we should be very careful. I'll tell you a couple of things that we learned in our Vancouver experience, BC experience, British Columbia experience. When we got agreement quite a number of years ago by my Premier Gordon Campbell to move the program of expanding, liberalizing the use of antiretroviral therapy in the context of a sort of the first iteration, if you want, of a field testing or test and treat. All of a sudden, there was no money. The economic crisis was a problem. They knew things were getting difficult, and so in a meeting with him, we made the decision to actually go to the epidemic, where the epidemic was worse. And so we made the conscious decision of saying, look, we're going to advocate for liberalized use of antiretroviral therapy, but we're going to put additional outreach resources in the two worst affected areas, and the worst affected areas in terms of morbidity and in terms of mortality. We were doing hotspotting without knowing it, and it worked like a charm. As we moved to better and better control of the epidemic, we needed to get more sophisticated. And that's when our Poon's work, the phylogenetic, real-time phylogenetic mapping that you saw, is the latest generation of hotspotting at the sort of micro level, which is a way of finding these hotspots on a real time as we go forward. Having said all of this, I want to very strongly go on the record saying that we need every tool in the toolbox, and we're going to need to optimize PrEP, and we're going to need to continue to promote condoms and education and everything else that works if we're going to bring this epidemic to its knees. And we are going to have to recognize that there are cascades for everything that we do, and that we need to characterize those cascades so that we understand where the problems are and how can we solve them. Recognizing also that a cascade actually hides a lot of information. And the more we look into stratified cascades, whether it's geographically, by gender, by age, or by multiple stratifications, we find niches of opportunities where we can bring interventions to actually improve the overall cascade. Which, by the way, cannot be fixed by looking at one step alone. It has to be looked as a continuum, and it requires attention to all of the stages. So my final comment, we need to continue to innovate, and that's not just innovating new medicines and diagnostics, but the way that we do things. And the way we inspire ourselves to innovate at the programmatic level is by monitoring, because at the end of the day, we cannot fix what we don't measure. And with that, I'll pass it on to you.
That's great. We'll open it up to Jane. Perspectives on the summit or what you've heard?
Okay, well, it's been a fantastic couple of days. There's been amazing presentations. I've learnt a huge amount. And I've taken away all sorts of different metaphors. So my metaphors are going to be very mixed about waves and various words. I just want to reflect very briefly on where we're at in England, because we are in the midst of change, tumultuous change, transitional change in our health economy, with our prevention initiatives and testing initiatives for HIV. Now the finances for that being devolved to local government, with our treatment and care budget remaining at national government level. So right thing, right place, right time has never been more relevant than it is in England as we speak now. In brackets, Scotland has not gone down this path, and so this is not something I can talk about as a United Kingdom issue, but as an English issue. And so here we are at the moment actually learning how to do localization and localism in England around HIV, and how to produce a system that will work and that will link the gains and the savings that might be made in the treatment and care part of the pathway with the increasing costs of increasing testing, perhaps in the hands of elected politicians locally who may not see it as a priority. So persuading, and for me the other big message from this conference has been language, communication and culture, because we don't understand each other. We don't understand what we're talking about. We're using the same words and we're meaning different things. And I think we've got to get that right. And we have to, therefore, use the language that will allow everybody in the system to prioritize HIV, sexual and reproductive health, because they are linked as a system in this country. How do we get that prioritization? How do we, I think somebody else said, it's gone quiet. It's off the agenda. What are we all making such a fuss about? Well, it's a huge amount of work still to do. And how do we make sure that we get that there? And I see that we've talked a lot, and the things that come to mind immediately, this has got to be prioritized across the piece. So it's got to be at the individual level. The people this affects need to be having it as a priority. We need a collective prioritization. And at what level do we do that? And of course a national and international prioritization. And right now, the priorities internationally, I don't think are in our favor. The priorities nationally are not in our favor. It is not necessarily on anybody's radar. And so we have a responsibility to get it onto everybody's radar at the right level. And the next thing to do that, the only way we get anybody to prioritize anything is the evidence. And you know, Julio, you're so right. If we haven't measured it and we haven't got the data, we are not going to be able to make the case to the individual, to the local authority, or to David Cameron, or whoever it may be. And the data, what is the data? I mean, that's the other huge issue. What is it that counts? And I really want to challenge the fact that the only thing that counts is an undetectable viral load. It's really important, but we're not measuring so many other things that really count. Are we measuring how many people who take an HIV test are negative and are still negative a year later? No, not in this country. We're sending them a text message and telling them they're fine. What's that doing to prevent acquisition? We're certainly looking at preventing transmission, but acquisition, and then how do we prioritize in what we're talking about, the hotspots, ensuring that a negative test is seen as a valuable piece of data. Because at the moment we're not necessarily doing that. How do we measure the well-being of people living with HIV who may elect to start treatment at a higher CD4 count in order to feel better about their relationships, better about themselves, better about a whole range of things, which at the moment we don't measure. We don't have that data. We just say, oh, well, it's a viral load, and that's all we've got to go with. So there's a big data collection issue. And again, know your epidemic in order to do the right thing at the right time in the right place requires the evidence. And so generating this evidence, how are we going to do that? Collaboration, communication, and actually ensuring that the people who are experiencing what is happening are at the forefront of making sure the evidence that is generated is the right evidence. We talk about community. I find it a very difficult word because I don't think I know what community means. Various people have put up a variety of definitions of community, but there are different communities, and the things that matter to perhaps the clinical community are not the same as people who are living with HIV, but I would suggest to you that people living with HIV are not a homogeneous community either. So we've got to be sure that everybody who has some evidence to give to this whole agenda has that evidence collected. And then how are we going to be ready? So we've managed to get the evidence, we're in the right place, we're in the right time, we've managed to persuade people to put the money where it needs to be. Are we going to be ready? What are we going to do? Are we going to have the staff? Are we going to have the right people in the right place? What is the capacity that we need here? And there are all sorts of really innovative things we can do. And I think the stuff we heard about task shifting is really important. I would challenge the speaker who said doctors and nurses can do it equally well. I think we know that. I think we've known that for a long, long time. It's actually bringing in other players. It's bringing in peer navigators. It's bringing in a whole different array of people who can do some of this work. I think that the issue between doctors and nurses is much clearer. We're not necessarily able to look at the other players. And I would just use an example we have at Homerton, where the Mac AIDS Foundation have given us a small amount of pilot money to actually employ 3 people who use our services to be properly paid members of our team. And we work in an environment where people often don't have jobs or don't have money. So that actually allows those people to have some training, to have an employment record, and to actually have social capacity. So we'd like to see more of those. So I think we've got a huge amount to do. The idea of cities, fantastic, but really if it's going to be right thing, right place, right time, then it's data and it's persuasion and it's language. At which point I shall stop.
Thank you very much, Jane. Patrick?
I think I would say that I'm a great beneficiary of this meeting, and I'm a clinician, I'm an implementer, but I would love to say that I have decided not just to be a clinician, but be an advocate. And when I'm not in the clinic, actually I sing and I do songs on HIV, and they're being played on air just to tell somebody out there that you can do something about it. What else have I decided to do? I'm a clinician, yes, but how am I going to ensure that we achieve the 90-90-90? I have to be involved in the creation of registers, creation of messages, right messages that are sent to patients. So I have to sit with the M&E team, the ICT team, and help develop those messages. I know I'm a clinician, but what am I talking about? Stakeholder involvement, multidisciplinary involvement. If we do this as clinicians in the house, then we are going to have a difference. I would just love to say that I know that as we implement the new guidelines, as more numbers of patients come to the clinic, in Africa, human resource for health is still an issue. And I know that burnout and issues of quality come in, but we have to make a deliberate choice. Let's turn off the tap. That means, as a clinician, I have to be involved in prevention so that fewer people get HIV, fewer people come to the clinic to be enrolled because we have prevented HIV. And then you'll have less work. That's how I look at it. That is one way we are going to address the burnout of the health workers and a lot of work. And then the field that we have identified, we are going to offer them quality services. So what is being talked about here is that as clinicians, as implementers, we definitely have to be involved. In relation to PrEP, as I'd indicated earlier, like in Kenya, we are implementing the 2013 guidelines. The only bit that we have not implemented yet is the PrEP bit. And sitting in the national task forces gives me an opportunity to go back and give feedback to the team. And when we discuss it in the national task force, I'll be able to share that which I've learned, and we can make decisions on how to implement pre-exposure prophylaxis. But something was mentioned about, as we implement PrEP, what about the other STIs? I think that was very critical. What are we going to do about it? As we wait for an opportunity of probably having PrEP that can serve again as contraceptive for women who do not desire to get pregnant. I mean, as we wait for that, what can we do now? So that is very critical. Media engagement, communication. I indicated that communication is very critical, and once again, stakeholder involvement. We have to sit down, discuss, and agree. We have implemented task shifting for the last, I would say, more than 5 years. That is in Kenya. And this was based on the fact that there were patients who were seen by nurses and some were seen by doctors. But it seems that the outcomes were better for those who were seen by nurses. Why? So as doctors, as senior clinicians, we have to accept that we can still task shift, maintain quality, and the patients will get the best service that they require to get. Lastly, just to point that out of these discussions, we had initiated a discordant couple register because we have to deliberately prepare for implementation of things even that are yet to come. So what did we used to do? We test couples. When we find the ones who are HIV negative, we have to call them again for testing. So we have to look ahead. We have to look ahead, even as we do the right thing at the right place at the right time. And I'm convinced that we are going to achieve this. Lastly, another thing that was mentioned in the last presentations was about involving the cities. We decided to have what is called a public health forum every month. We come to a hall like this, someone does a presentation, an expert does a presentation, then we have the members of just the community, members of the community ask questions. And with that, we can give them the right information so that they don't hear the information somewhere else that is distorted. And I believe that probably the city I come from is one of the cities considered. Thank you.
Thank you, Jose. I want to share with you a case study from Peru, which is a contradictory case study. By one hand, there is an institution named Impacta, which is a state-of-the-art clinical research organization that also have very good links with the gay community and provides STD and HIV services to thousands of MSM in Lima. On the other hand, there is a government that have a closed-door policy for the last 5 years, where there is a lot of information provided by the research institutions in the country and by also the advocates asking for changes in the policy of the government. And this didn't happen in the past 5 years. For example, I can tell you that the number of testings have been decreased, and in the last Sentinel surveillance in the country among MSN, 40% of the MSN never had an HIV test. Also, Peru has the last change from 204 counts to 350 just 1 year ago. And even now, there is no Truvada in the country for treatment, neither for treatment nor for prevention. So this right things, right time, right place has been a moving target for us. Fortunately, now the government has changed authorities and suddenly things have changed. They have called us to work with them for new guidelines. We will help them to train primary healthcare providers to open up the treatment, for, not just in hospital but also in health centers. And Truvada has been approved. It's going to be the first vote for next year. So things can change, and so the take-home message: will you never give up? You need to ever be there at the front door to wait to be open.
I think the idea of treatment as prevention or controlling the HIV epidemic with treatment is something that we obviously will need to live with for a considerable period of time. And what I would like to just clarify, perhaps, and I was thinking about this when Julio was referring to some potential misunderstanding, and it threw me back to a session I chaired during the Melbourne conference, at which somebody did a research to assess how phrases such as or approaches such as treatment as prevention is confusing the community. And at the time, I had a lot that I wanted to say, but because I was co-chair with Godfrey Henshaw, I found my hands tied somewhat, and I became a politician at one moment, which I do regret a great deal. But what I would like to perhaps, what it really reminded me, as I was just listening to Julio just now, is that when you look at the community and we think about things like treatment as prevention, this is something that is, or even the misunderstandings amongst yourselves as clinicians, as physicians, as researchers, is really your business. As patients, we really don't care. We really don't have a patience. Half of us don't even know the pills we are taking. If you ask me what treatment are you on, I forget my treatment, and I'm in London, and you ask me, oh, what are you, can you give me, and I say I need ARVs, and you ask me, most people will not even know the names of their pills. And people actually then expect them to know what treatment as prevention is as an approach. I think that is too much to expect. Because one, we fail to educate our patients. Two, the treatment literacy programs are the ones that are being cut by Global Fund and its health systems strengthening funding. And community advisory boards are receiving the least consideration in treatment programs. So from our perspective, what we want to see is action in the care mechanism, that things actually work. And the people who know that are yourselves. You know what needs to be done. I like this phrase, the right thing, the right place at the right time. You know what needs to be done. All we want are the services that people want. And the services that people want, and Ben actually got me really emotional. And again, it was sad that we couldn't ask questions. And as I thought about the quality drugs that are coming out, and which are not, well, even though they're becoming licensed, are still not available in low and middle income countries. As I thought about how we are even regressing, that Global Fund, because of the tightness of the funding, Global Fund is reversing even things that are in the guidelines, from fixed dose combinations to 3 pills, which are going to impact, which are likely to impact adherence and are going to have an adverse effect on treatment outcomes of people living with HIV across the globe. As I thought about the choices that are available to certain populations in the world, and that issue of equity, how it's lacking, and in practice, so this is really a really big luxury. And so I am hoping that somehow from this conversation we will resolve, and as many have said, we will move on to put into practice the things that we know work, where we have the evidence. I don't think we need any more conversations. What we need is to implement them. And I want to leave you with my own marketing. I started in marketing many years ago, and as I think about Debbie's right thing, right place, is that you put people, the 4 Ps. I think some of you now, I think there may be 10 Ps by now, but in my old days there were only 4 Ps, and the first one was about people. And the people living with HIV will remain at the center of your interventions, that they will always be first. Your programs never supersede the people that you have to provide care for. And that every time we lose a person, we will be heartbroken and not continue to be desensitized that we share data about, a couple of other thousand people died. So many people have died. And we don't even give it a second thought. so that we would make people living with HIV and people that we need to prevent from HIV infection at the center of what we do. And the second thing I wanted to also talk about is going back to the issue of the products that we produce, that there will be high quality, where we can provide the highest possible quality, that have data, and I think Ben challenged us in that respect, that we have the data about their robustness, their effectiveness, and efficaciousness. This is the focus thing with Michelle. That, we would make this and do everything to get these products to the people that need them, to, again, improve their health outcomes. And then again, the third thing I want to look, and then of course they must be provided at the right price, that Peru, Mexico and others would not be left behind as is happening in this day. The third one is going back to the place. That we would begin to know who needs these treatments. We don't leave out key populations. We don't leave out young people. We don't leave out women. We don't leave out transgender. We don't leave men who have sex with men. But that we are able to take these products to the right places where they're needed. They're needed the most, including sex workers in generalized epidemics. I was shocked in Rwanda last year that the prevalence among sex workers in Kigali is 56%. And this was data shared by the National AIDS Council, whatever it's called, in Rwanda. And so we know what we need to do there. And then in that respect, we might begin to think about treatment as prevention in a much broader sense. We might begin to think about PrEP. We might begin to think about other, for negative sex workers and so on. And the last thing I want to also then talk about is promotion. One of the things that the climate change group do very well is promote. They use the media and the influence everywhere you go. I mean, I don't even believe half the things they say, but I'm forced to hear them every day. And if I was a politician trying to make a decision about financing, I cannot ignore them, because that's where my vote is likely to come from. They're influencing young people. They're influencing, So I think we need to promote what we're doing and be proud about what we're doing and what we need to achieve, and get the media behind us. Thank you very much.
Thank you very much to the panel. I personally could not be happier with the outcome of the last 2 days of very robust discussion. We've achieved so much in the last 33 years, from a time in which HIV was a true death sentence to a time and place where we have the ability to save countless millions of lives if we set our minds to it. I quoted Yoblanga, as did Michel, during the opening yesterday, and his prediction that an AIDS-free future is possible. He's right. We have the tools at our disposal to make this happen, and I'm convinced that as a result of gatherings such as this, but more importantly, going back to your cities, your work, that we will amplify the messages from here and accelerate the pace of our work. Michel said we need to aim high, setting bold new treatment targets for 2020. We need to support UNAIDS. We need to support PEPFAR, all implementers in trying to achieve that lofty goal. Finally, thank you to all of the distinguished faculty, to the co-chairs, to our partners, and to each of you for having joined us over the last 2 days. We hope to welcome you back again next year. Thank you very much.